So that they've got it for use there.
With pediatrics.
And you're up.
Anybody take care of a critical child? Yeah.
We had a 26-week delivery drug baby.
Okay.
That was not fun. Opiate baby.
Okay.
So Apgar was not great.
Okay.
And luckily.
So now you understand about Apgar. Okay, you can't say just great. Okay.
Yeah, no, it was so cyanotic limbs, not much muscle tone. Not really crying too much.
Yeah. The bad news bears, right?
Bad news bears.
Yeah.
We weren't doing CPR yet. We were doing blow-by. We were actively warming.
Yep.
We were scared, toothless, and
Yep.
we ran. And of course, this is like, 4:30 traffic in the afternoon, trying to run code 3 the heart, like tail between your legs, butt puckered.
Yeah.
And we had moms. We had no other ambulances close to us. We had 2 patients, my medic and 3 other medics on board. It was not a
That's a challenge.
It was
Good. Who else? Critical P.
I think critical. Septic 9 year old time. Kind of history of developmental delay. Recently sick with an upper respiratory viral. Turned into a pneumonia type deal. High fever, hypotension, tachycardia, kind of in and out of consciousness.
Yeah.
Trauma. Southern Idaho, where I work, and in so a lot of trauma patients. Lost their limbs to an accident, trauma, and a couple of choking, a couple of one child that they guessed that they blade plug-in.
Yeah. So, like I said a long time ago, and it will come back home today. What percentage of patients of yours are pediatrics? You suppose?
2%, 5%, 2 to 5%.
So probably closer to 10%. I mean, the overall scheme of numbers, the average is about 10%. So 10% of the time you're going to be spending with kiddos. Of that, how many of them are critical?
high risk, low risk.
Yeah, so another one of those less than 5% in terms of what's good. And so I would invite you. This is Dr. Phillips. She is from Pediatrician with Sacred Heart. She'll be with you for the next 3 hours, give or take, and she's going to pediatrics with you. But with that, I would invite you to dig into what she's talking about, dig into the materials and everything else like that, and the experiences that she's going to give you along the way. So again, like you said, it's low frequency but high risk in terms of some of the things you're doing along the way. So please tune in for what's going on, both for life and for me as well. Okay? Thanks for being here, ma'am.
Of course.
All yours.
All right. Folks, I'm Julie Phillips. I am an attending over at the Pediatric Emergency Room at Sacred Heart. I've been in that role since August. Before that, I worked on the East Coast at a teaching hospital in Pennsylvania, fellowship trained at Vanderbilt in Nashville in pediatric emergency medicine. That's where I actually found my love of classes like this and all those people that do my pre-hospital work, because before that, I always said, why didn't they do this? Why didn't they start the line? Why didn't they splint that? Why did they just scoop and run with no history? And then I got out into the classrooms and started working with the fine ladies and gentlemen that work pre-hospital, and I suddenly said, oh, their world is very different from my controlled hospital setting where I've got bonus hands. They had a flailing mother who was screaming and hysterical and just said, that baby looks sick and we need to get them out of this situation in there, so we're just going. It made a whole lot more sense what you guys do to me in that time. And so I take these opportunities as a chance to come back and work with you guys to do my best to help you out with those patients that you are doing a small percentage of the time, but as we said, can be really high risk because my kids don't behave like little adults. That's, that's the mantra of peds. They're not just little adults, they're different. And you guys aren't doing pediatric emergencies super frequently. So you'll walk out of this class and you're like, yes, I got it. And 3 years from now, one of the situations that's in there will come up and you're like, oh, there's something I'm supposed to remember, but I don't quite remember what it is. So With that being said, I am somebody that interacts with the group, so stop, ask questions, give comments. If you don't understand, we'll go back over it. And I'll be available afterwards if you have a burning question or a great story that you want to share about some traumatic peds experience. As you're saying 26-weeker, I'm thinking the 23-weeker that I had roll in fellowship, and we said, does anybody know where the 00 ET tube is? And that's super, super tiny, and where, or the 2.0 ET tube and the 00 Miller blade are, because that's how tiny things have to be to intubate something that's 500 grams. All right, so let's get started. Today we're going to go over some different things. Growth and development, because my kids aren't the same. They are a rapidly changing group of tiny humans for the first 5 years of their life, really. And then you break them into school age and adolescence. So there's things with each of those groups that you need to know and understand to make yourself a little more successful in your job. We'll go over some anatomy and physiology things. We'll talk about a pediatric assessment. Then we'll go through some pediatric airway and shock management information. That's the high yield stuff, because those are the things you're going to want to know. What do I do when, and how do I distinguish one thing from the other? And then end up with some common pediatric illnesses. So growth and development. We're going to start at the teeniest little weevils that I see, and then we'll move all the way up through adolescence. So neonates, that's the first month of life. This is one of those major developmental stages where they can't really tell you much. And here's a parent. All right, who has nieces, nephews that they've been around? Those of you who haven't yet raised your hand, babysat, have a neighbor that's got a kid.
Seen one on TV.
Seen one on TV. So these little guys are a really, really tough group because they can't tell you anything, and they are new to their parents. So what's normal? We don't really know yet, because we've had this one for 4 days. The other challenging part with these neonates, they come with really sleep-deprived parents. So you may be asking for a history and get really glazed look as to they can't even really remember why they called you, because they're sleep exhausted too. In this group, your gestational age is going to affect your early growth. So if you are a term baby in this page and you are 3 weeks old, you may have been 8 pounds at birth, and you at 3 weeks old have gained another 1.5 pounds, and so we're up around 8.5, 9.5, 10 pounds, and you're a nice little chunky baby. You may also be a 35-weeker, a preterm infant, who still is not yet supposed to be born, but you're 3 weeks old and at home, and you may only be 5 kilos. So there's a lot of difference in that. The younger you are, the less subcutaneous fat you have, the more you guys need to be really aware of keeping them warm. They are very, very susceptible to hypothermia in this age group. Common things you're going to get called for: jaundice, so the baby doesn't look right. And jaundice may just be that they're yellowed, but jaundice may also indicate something like sepsis, because you don't just turn yellow while you're turning over your hemoglobin. It can be illness. Jaundice results from poor feeding, so that may be we're jaundiced and hypoglycemic and dehydrated. So that can be more than just yellow and I need some phototherapy. Vomiting is a big one that you're going to see. With these guys, they don't have a lot of muscle tone, so when they vomit, their aspiration risks. They typically live their life supine. They're laying flat all the time, so they can vomit into their mouth but not actually get it out into the world. And then respiratory illness with distress is another really common thing that you're going to see with this group. Again, they're really young, they're really tiny. They're obligate nose breathers. So you fill their nostrils full of snot, and now they don't really have much of a way to breathe. So it doesn't take a ton for a baby to get in trouble. Serious illnesses are really difficult to distinguish from minor illnesses. Is he upset, cranky, and crying because the diaper's wet? Or is he upset, cranky, and crying because something hurts? Or because he has blood in his brain? Or because he's sick and trying to tell you something? Parents don't know the cries yet at this age. They haven't yet nailed that one's hunger, that one's poopy diaper, that one's something's really wrong, that's faker yet. They'll get that as the kids get older, but that makes it tough. And also, again, this is a patient that can't tell you anything that's going on. They can just look bad. And it may be something as simple as, I need to feed. But it may be, I'm septic. Any fever in this age group needs to come to me in the emergency room and needs a big workup. In this age group, they are working solely on mom's immune system. So they have gotten a bunch of her immunoglobulins through the placenta. If they're breastfeeding, they're getting more that way, and they're just barely waking up their own. So in this age group, a urinary tract infection easily spreads to the bloodstream, which seeds the meninges and makes you be meningitic and septic without much difficulty. For these kids, when they come to me, if they have a fever, 100.4 or higher, they are getting blood cultures, urine cultures, a spinal tap, getting started on antibiotics, and being admitted until their cultures are negative, minimum across the board. Because we don't trust them, and we don't trust that their immune system is going to handle things the way yours would, or even an older child. As I mentioned earlier, keep them warm, keep them warm, keep them warm. They don't have a lot of subcutaneous fat, and cold babies do not do well. Absence of tears is one of the things you're going to look for. Is you're messing with a baby, you're taking them from their bundle in mom's arms and taking that blanket down and taking down their pajamas and making them cold and naked. Parents, what happens when you make your baby who is brand new cold and naked? What do? Cry and scream. So when they're doing that, take a look. Are there tears? That can be an indication they're dehydrated. Okay. When you start running out of fluid, the body starts saying, what else can I do to steal some fluid from extra places? Well, I don't really need to make tears anymore. So if they're just crying and inconsolable, but nothing's streaming down their face, that can be a sign that they're dehydrated. All right, moving up a little bit, our next age group, infants, we're breaking them into the early and the little bit older, the 1 to 5 months old. This is where we're starting to pack on the pounds. We're going to start to become those chubby little Gerber babies that everybody likes in the commercials that are so cute. And they are starting to now become aware of their surroundings. That neonate just wants to be warm and snuggled up in a little ball. These are starting to be the kids that are staring at the fan on the ceiling because, whoa, that moves. That's pretty cool. Hey, this hand, I have control of it. They are starting to develop more of their motor skills. So in that neonate, you've got to be really careful with them. They don't have a lot of muscle tone, so you want to make sure you've got good support of their head and their neck when you're moving them around. This group, you're going to start between 1 and 2 months, you're going to get good head control, so they should be the baby that if you hold them up, they should be able to look around. After they start to do that, they get more trunk control, so they'll be holding their shoulders up more and their body up, and you have to do less of the work supporting them upright. They'll move into being able to roll both forward to back and back to forward, and kind of at the end of this age group, they can tripod sit, which means if you plop them down on their butt, they usually can fall over onto their hands and use 2 anchors of legs instead of hands to hold themselves upright and look around. Again, we're wanting to keep them warm and comfortable because even though they're getting chubbier, they're still not good at maintaining that temperature to the cold environments, especially here in winter. The back of the truck is not a toasty place to be. And then the common things that you're going to see is dehydration and respiratory complaints. You're going to get less of like the fussy baby calls and they're just not acting themselves call. You'll still get some of those because parents are still learning them. But vomiting and dehydration are one of the big ones. Poor feeding can lead to dehydration. And then this is another group that's really susceptible to things like flu, croup, RSV. And in this group, especially the ones under 3, fever's still pretty important. They're not going to get the massive workup that the little ones get unless there's a big red flag in their exam. But most of them under 3 with a fever will still get blood and urine cultures. I already went through the progressive, switching. So 6 months to a year, the later infants, we're going to continue to progress those motor skills. So we left off in our 5 months old are probably tripoding. Now at 6, you're going to start to sit by yourself, and then you're going to learn to crawl. So you'll see them on all fours, kind of scooting and booting and trying to convince themselves to go. And then one day they take off and start moving. Then they pull to stand, and then eventually we'll start walking. Some around the year mark will be walking. Others won't make that until 15 months of age. These are really active little beings. Now they see the world, now they know humans, and they want to figure out what is all that's out there. And they explore their world through their mouth. So this is a place where you're going to get calls for ingested foreign bodies, aspirated foreign bodies, but that's also a risk for you guys in the truck to be the cause of their foreign body. Remember simple little things like when you take the cap off the saline flush on an adult, if you drop it on the stretcher right beside them, unless they're developmentally delayed or a psych patient, they're probably not going to have grandma pick that up, pop it in her mouth, and start chewing on it, hit a bump, and aspirate it. But a 6-month-old might go, "Ooh, what's this?" And they're quick, and they'll get it in before you even know. So as you're using your equipment and setting stuff out, make sure to keep small things out of their reach, and use if you have to use your partner to hang on to things, or just drop it on the floor, that's better than adding a second chief complaint to your patient that you're transporting. It's poor form to be like, "Hey, they're here for dehydration. By the way, there's probably also a needle in there." I'm just a warning. These guys are going to have more formed personalities. These guys you're going to start to know. Their parents are going to be able to tell you, "This is my happy baby. This one never is afraid of strangers, and something's going on because she's not right. Oh, this one's really shy. They're a little reserved. That's my gregarious one. He gets into everything." They start to become more what they're going to be as they age in this group. And unfortunately, this is where stranger danger starts to hit. So this, up to now, they just know there's people out there, and you, the medic, maybe Dad, you may be Grandpa Charlie, you may be the guy that lives across the street. I don't know, but you're another person that's interested in me. After 6 months of age, they start to know, "I don't know you. Ooh, stranger, why do you want to hold? That's Mama, and I want her. I'm back over there. Why are you touching me?" You get so they start to be a little bit hesitant to let new people around them. That's going to become a little bit more important as we get older, because then stranger danger really hits, and you've got to modify what you're doing to sort of build those relationships to even be able to assess the kid. Because we're starting to get that stranger danger, enlist mom, dad, caregiver, whoever this kid knows to help you out. If it's not a severely ill kid that you're just kind of scooping and getting off scene with, if you're going to stop and do your full assessment before you head out, have the parents sit down, put the kid in their lap, start at their toes, work to the top. Feet are much less scary to be touched than if you come immediately with your flashlight and put it right in their eyes. You've gotten into their little sensory bubble up here, and I don't know you, and now you've got that weird thing, and it's all up here by my head. I'm not having this, and they'll have a tantrum and come apart, and you're gonna not be able to get nearly the exam you are, as if you start far away and work your way to the top. All right, moving into toddlers, 1 to 3-year-olds. Anybody heard of the terrible twos? It's not just the twos. It starts in the 1s and progresses to the 3s and the 4s, but that's this group. This group is going to have a lot of gross motor development changes. So now they are mobile. They walk, they run, they climb, and they tend to be constantly in action because, again, they're trying to figure out their world, explore, figure out that something changes, something new, so they're all over everything. This is a group that's going to be high risk for injury because they are brave, they are curious, and they are stubborn. Anybody have a kid that wants to climb on the counter regularly or climb high? And how many times do you say no and they still keep doing it? Yeah, constant battle. They start to get smart enough to try and figure out the baby gate because they're watching you, so they know, well, I'm not allowed out there, but there's probably something cool that I should figure out what's over there. So they can do things that hurt themselves because I really want to know, and they're a little bit fearless because they don't know they shouldn't be doing that parents are putting things up to protect them. This is where your language skills are going to start to develop. In 1-year-olds, you should be expecting them to have a handful of words they know. Mama, dada, baba, milk. So single things that they're going to be saying. 2s, you expect sort of 2-word sentences. So me go, that means I'm going. Mama milk, Mom get me a drink, I'm thirsty. And then as they move into 3-year-olds, they're going to start to make a little bit more complex sentences. The older you get and the more verbal they are, one of the ways to build trust is to talk to them a little bit. Now, you can't say, when did your chest pain start? And expect them to answer that. But does it hurt? Can be something they probably can answer. With this group, they are going to be your accident group. They are the ones where their leading cause of death is accident. And that's true from this group all the way up through 15-year-olds. Approach them quite slowly. This is really the stranger danger age that I was alluding to earlier. Try and gain their confidence if you've got the time. So if they're clutching a teddy bear, do what you're going to do to the teddy bear first. Or if you need them to open their mouth, for some reason they're all terrified of opening their mouth, even when you're just holding a flashlight and promising to not put anything in there, becomes the response they give. They clench down. You know, how about Mom, open your mouth and show that you can do it. Or you can look in my mouth. Or Mom will hold the flashlight and I'll just look. You have to do some things with them to try and gain their confidence to be able to do what you want with them. These are still teeny tiny little people. So those of you that are bigger build, you may be very intimidating to them. So if you are that guy that is 6'4" and should be playing tight end for the Seahawks, but you blew out your knee in high school so you can't, and you have a big, deep, imposing voice, you may terrify this child, but you get down to their level and you drop your voice and you use softer voices, reassuring tones with them can help you to build some trust with them and be able to do what you want. The last one is pretty key. Allow toddlers to hold on to transitional items. Anybody know what a transitional item is? Transitional item, blankie, teddy, whatever they call it, dolly, whatever it is. That's what parents are using to transition and give this kid confidence. So if they're clutching it, that's their superhero power that makes them brave. And if you are trying to build confidence and the first thing you do is snatch it out of their hands and throw it in the back, tantrum is coming and you are so mean. And I don't like that guy, regardless of what he does. All right. So preschoolers, 3 to 5-year-olds, this is a really fun group because, as the 4th bullet point says, they've got their vivid imaginations. These are the kids that while you're going to try and get some history from them, you may be led on a really long story about it. You may also have to endure listening to the neighbor got a new puppy and a whole story about that before you get around to the fact that they feel icky today. So they're really fun. They got a lot more language at this age, so they're going to want to talk with you. They're trying to learn that in the world. So you may end up with a chatterbox in the back that just tells you about everything on the way there. But you can use that to your advantage, again, to gain trust and be able to interact with this kid a little bit more. In this group, the 3 to 5-year-olds, we've gotten walking, running, climbing, those sort of things down. Now we are perfecting that stuff. This is the group that can start to skip. That's a little bit more of a challenging movement. They can do long jump. They can start to walk on a balance beam. So they're starting to put their gross motor to really good use. They're still not great at it, so they may try and balance beam and fall off pretty easily and end up calling you for that. And then they're also working on a lot of their fine motor skills. So these are the ones that are going to start to do more writing, coloring. They're going to be using a spoon or fork to feed themselves rather than just using their hands. This group is really comforted by home and being around their parents. So with them, being able to do whatever you can in their comfort setting is going to help them do the best. And this is another group that having the parents for help is really important. Question them first. Let them have a little bit of power in this because they want to think they're bigger than they are and they like to interact. So you can, if you can, come up with some questions, talk to them first. And then you're going to get a crazy story that you're like, oh, there's a lot more to this. And then you look to mom or dad and say, all right, can you fill in the rest of what's going on with this little one? But these are big kids. So do you have an owie? Oh, that boo-boo hurts is not the way to talk to them. These kids definitively know I'm not a baby anymore. And that's how you talk to babies. So don't do that with them. And then allowing them to hold on to something that you're not using can really go a long way. So I often in the ER, after I've listened with my stethoscope, I hand it over to the kid and they're exploring it and looking at it and pulling it and twisting it. And I can do a whole lot of the rest of my exam because they're distracted with that and they're feeling important. They're feeling like they're getting a chance to do something. All right, now the school age kids. If you notice, the age ranges are starting to get longer. So 6 to 12 is our school age kids. These are the good old days that you remember from childhood where everything was fun. You didn't really realize that there was anything real wrong with the world. So they're active and carefree. They're going to continue to develop their personalities. And so with them sort of trying to get a peek into, is this the stubborn kid? Is this the kid that's really interested in, say, science, and they may want to know everything that you're doing and the why. This is the kid that you're transporting and they're looking at your monitor. What's the blue number? What's the white number? Is that okay? It beeped at me. Is that okay? So you may have to do a lot of that with them because they're inquisitive and they want to know what's going on around their environment. They value their peers. They still like mom and dad in their opinion, but now we're starting to trend towards I'll care a little more what my friends think. And the friends are starting to become more that comfort system. With them, again, you can let them provide the history if they're willing to talk to you. The shy ones a lot of times will kind of duck away and not be willing to do that, but at least give them the opportunity. With them, be honest. Don't go, I'm going to start this IV, it's not going to hurt. We've all been stuck with a needle. It hurts. It doesn't hurt a long time, but it does hurt. So if you start out with, let me see your hand, this won't hurt a bit, and you poke a needle in there and it did, you've lost your trust with this kid. And it's going to be hard to regain that. So just be upfront, tell them what they're going to do. And with them, also tell them what's wrong. Tell them, why you were called, what you're going to do. We're gonna get in the back. We're gonna go to the hospital. The doctors are gonna check you out there. They want to know and they want to be involved with what's happening. And the younger they are, having a small toy may help to calm them. A lot of ambulance companies I've worked with previously get donations. Keeping a few of those stuffed animals in the rig that you can hand over to give this kid a comfort item may help, because even though they're 7 and they've sort of moved out of that range of carrying their transitional item, when they get into a traumatic situation, they may regress a little bit and act like a younger kid. So giving them something that's comforting and soft and snuggly may help them out. Oh, sneaking back to the last group, just a key. Don't ask what you're going to do, tell. Can I listen to your lungs? And they say no. Now you've painted yourself into a corner because you have to do it, but you've given them the option to say no. So you can give them choices that you're okay with. I need to listen to your heart and to your tummy. Which one do you want done first? So you can give them some power, but still saying, I'm doing all the things I need to do. Adolescence, so this is beginning at puberty. 13 to 18 is classically the age we think of. This is a quite variable age, all right? They can be really mature at 13 and be able to tell you their medical history and the surgeries they had and what doses of medicines they are and when they take it. Or they may be 17 and have zero clue what they ate for lunch. So just be kind of cognizant of that it's a huge range with them. This group is really body conscious. So when you're examining something, privacy is important. As girls more than boys, but both genders are really concerned with being normal and just fitting in. So if you need to look at their abdomen for a seatbelt sign, you absolutely need to do that for your job, but have a sheet and say, I'm gonna throw this over you and then lift your shirt up. We're not gonna let everybody see. If you've got to cut their jeans off because they're a trauma patient and you need to see what that femur looks like, have a sheet ready to go to throw over that you can peek under, because a lot of them will be mortified to just be somewhere in their underwear. This group thinks they're grown-ups. As they get to the end of it, they know everything, you know nothing. Be ready for that, it's fun. As I said, they really want to be like their peers, they want to fit in, they want to be normal. This is where you're gonna start to hit those kids that have strained relationships with their parents, and I'm sure anybody that has any pre-hospital experience has been there, where you get the kid that looks at their mom and snaps, no, that didn't happen, or I never said that, or you're making that up. That's pretty typical of this group because they think they're adults and they think they're in control and they think they know everything. This is where you've got to start thinking about pregnancy in your patients. So a young lady that you get called for vaginal bleeding, maybe miscarry. Be sensitive about those sort of things. Your vital signs in this age group are going to be much more like the adult ones that you're really accustomed to. Listen to what they're saying and what they're not saying. You often will get a sense there's something more to the story. One of the things we always train the residents to do and the med students is during your interview, get some alone time with the kid, because I had sex for the first time and I'm scared I might be pregnant is probably not something that they're going to say right in front of mom. But they may have called you for belly pain and nausea. So if you have an opportunity when it's just you and the patient, give them a chance to say, you know, is there anything else going on, anything you don't want to say in front of mom, and let them know they have some rights. So those sorts of conversations are protected, and you can't just turn around and tell mom, hey, she had sex last week. So let them know the stuff that you're going to tell me, unless someone's hurting you, you're hurting someone or you're going to hurt yourself, I can't tell anybody. So that they have that opportunity to disclose something extra. If you feel like there's something more to the story that they're not saying, there probably is. With them, go for it.
Just out of curiosity.
Yes, sir.
They do tell you that they're pregnant.
Mm-hmm.
When does that get passed on to the family?
Only when the child is willing to disclose. So I have had many a visit where I have spent time in the room with the kid begging them to tell mom what's going on. I am legally not allowed for a teenager to say they are pregnant unless I have their consent. So I talk to them about, you know, is there an aunt that you're close with that could come in and join us and we'll tell them together? Do you want me to tell mom? Do you want to tell mom? Do you want me in the room? Do you want the social worker in the room? Yeah, in the pre-hospital setting, unless the kid goes, can you tell mom? Which probably is going to make your transport really dramatic. It's probably one of those things better left unsaid. Pass it on to me outside of the room, outside of earshot. Hey, she told me. And when you're telling her, unless she's like really ready to say it right then, be like, well, we'll let the doctors know, and we can do that together when we get to the hospital.
What is that the same with all medical conditions? And at what age does that are they able to make their own medical decisions? Like if you have a 15-year-old who say the parents are like, no, you're going in by ambulance to get checked out, and the 15-year-old doesn't want to.
So parents have medical decision-making power for that until 18. Once they
Exception of pregnancy or
for all of it. So parents can if they're concerned, they can say, I want my child to have a medical evaluation. All right. For me, I can't force that exam on them. So if you're into one of those situations where the kid's adamantly refusing to get in the car, parents are insisting. Legally, the parents have the right to get their kid evaluated. Use medical command. Okay. Don't be stuck out there and have all that liability on yourself.
So even though the parents can insist on a medical evaluation, they can't know the results of that medical evaluation?
Correct.
And that applies to 13 or older? Or
13 or older, so the things that I can't disclose without the patient's permission, they have right to privacy for pregnancy and sexual health, sexual orientation, drug use, and mental illness.
But anything other than those you can disclose?
Yeah.
Like diabetics?
Oh, yeah.
So
Diabetics, parents get to know. Asthmatics, parents get to know. Crohn's disease, parents get to know.
okay,
My
so it's only those,
13-year-old
they don't get
Or a 13-year-old's not getting prenatal care, and the parents don't know any better to get her, force her to get checked at until she's got a baby.
Yeah, it's a really sticky situation, and so like I say, in the field, it's not going to be one that you're going to have to deal with. That's a get them to me and give me the hot mess, and that's where social work really helps out, because we do a lot with our teenagers that are pregnant or have substance abuse issues, those sort of things, to really encourage them to make this a known problem to the family. We say things like, this is not something you can hide forever, and having your mom on board would be, more helpful now. If you can't find it, if they're adamant not for a parent, most every kid has at least an adult in their life they trust. And so if you can at least get them to that person, Aunt Susie can help to take over and continue to encourage this kid to, let's be honest with mom and dad and let them know exactly what's going on. Do you have
Does that go in the same line as emancipated minors and everything like that?
So emancipated minors are a little different. So emancipated minors now have gone to court, and they have legal documentation that they no longer belong to their parents.
But they're living at home, their parents are still their guardian?
So if you're an emancipated minor, you have stripped your parents of their guardianship. So now you are legally responsible for yourself. Emancipated minors, so every state's a little bit different, and I'm not perfect on Washington law because I've only been here for a few months, but emancipated minors typically have to prove that they can sustain themselves and to support themselves. So emancipated minors very rarely live at home anymore. This is your 16-year-old that is going to school, working a job, and rents a room at a friend's house, has their own apartment. So they're a little different. But yes, if they're emancipated, they're the ones that have the right to make their own decisions.
With the psychiatric
Yeah.
privacy, if you've got a kid that got called to because they've got 2 broken arms, you can't tell the parents that their arms are broken because they were jumping off the roof trying to kill themselves.
So remember the thing that I said in your privacy. You have the right to privacy unless someone is hurting you, you are hurting someone else, you are hurting yourself. So that falls into you are hurting yourself.
Only if they're trying to then we know.
I didn't go to law school. I went to medical school. I have a biology degree. Yeah, so like I say, Legally, they have the rights to those things, but the what you can call, self-harm and not is a tough place. And I'm just going to leave it at that because I don't know the actual legal answer to whether we can
Try
call.
to defer it to the doctor and social worker.
Yeah,
Get him to trust us and then we tell you.
correct. And on that note, if they disclose something to you in the rig, that is important like that, disclose it to me when I get there, because that kid so they were fine for the beginning of your transport. They were back there, they were talking, and then something happened and their mood changed and they no longer trust you. And by the time you're there, you've got them in 4 points and a spit screen. And I'm putting them in my isolation room. I'm probably not going to get that same history because I'm going to just have an angry child that needs isolated to de-escalate. You may have an important piece of the puzzle because that change may have been, the pills they just popped have hit, that the meth they just took has now taken over this child. So if you can get some of that, it's really useful for me.
Do the other peds docs share that same philosophy of just dumping all that on them and letting you guys deal with it, or is that just?
I haven't, so it's not a discussion that I've had with my partners, but that's a really tough place to be in what you do. You have them for a little snapshot of time, and to be able to then become their social worker and therapist and deal with all of those things while getting the rig reset for the next one and going for the next call. You may not have the time to do that. And so we understand that we get a lot of that dumped to us. We also dump a lot of that to social work. So, it's a team effort. You're part of the team, we're part of the team. So I don't think anybody's gonna call back to your base and complain specifically about you. Like, yeah, he found this ticking time bomb and just dumped it in my lap. That's what we do, and that we understand what your role is and what our role is. With them, so we touched on some of the things they do that are high risk. So homicide and suicide are now going to start to climb in terms of death rates for them, almost equaling that of unintentional injuries. With these kids, respect their privacy. Like I talked about earlier, we're keeping them covered, we're keeping them modest. If they are absolutely adamant that they don't want to talk to you about what they did, it's going to be a harder transport for you if you just keep badgering them and keep asking the same question. You can just kind of give them a warning, like, that's something that's going to be really useful and more people are going to ask you. So if you don't want to tell me, you're probably going to hear that same question later. With them, provide a lot of psychological support and reassurance. The kid that got called because they took an overdose, it's not the time to browbeat them on the trip into the ED. Why did you do that? That was stupid. That's not where the kid is emotionally. So, you know what? People make bad decisions. I'm just glad that someone called. We can get you to the help that you need. That's a better statement for them. That's going to make your ride safer. That's going to keep this kid in a little bit better state when they're already in a very fragile state. All right, so moving on to anatomy and physiology. So babies are not tiny adults. I've said it now 2 or 3 times. Their bodies are quite different. So their heads are much, much bigger than the rest of their body. They've got a big noggin to support. I say this because it's going to make some differences when we're doing things like positioning a patient to maintain their airway. If you've got a giant occiput and you're laying totally flat, your head's tipped forward. It's pushing you. If you're trying to open up an airway in a patient with a respiratory distress, is the answer tip their head forward and push their chin down? No, what is it? What are you supposed to do? Open up, yeah. So, and then you gotta consider how they're positioned and look at sort of the back of their head and how they're lying once you get them flat to say, maybe I need to throw a towel roll or some folded blankets under their shoulders and back to even them out and keep that airway open. They also have small faces on these big heads, so it can make getting your seal of your mask pretty difficult. You're wanting it to cross the bridge of your nose and come across the bottom of your chin. With adults, there's a nice rounded area to that that fits nicely in. Being very flat, sometimes it takes a little bit extra pressure to get the seal on the sides that you need. With the little ones, inspect that anterior fontanelle, so that can give you some knowledge about what's going on. A dehydrated baby will have a divot. A meningitic baby can have a bulging one, but remember, not all bulging means meningitis. Pooping can make it bulge, crying can make it bulge, things that cause Valsalva and like bearing down can make it big. But if it's bulging, consistently in a baby that's really not doing anything other than laying on your stretcher, it's a worrisome sign. Hints. Yep, I'm just pooping. All right. So that big head is relatively heavy compared to their body size. So it leads to trauma problems. Its balance can be off. Their center of gravity is higher than an adult. And that makes them fall a lot. Whose toddler has fallen and hit the coffee table? Or the fireplace, or the door frame. They're starting to get upright and starting to get ambulatory with a big watermelon up top, so they do tip over. As I mentioned, this is going to affect our airway, so we got to make sure that we're appropriately positioning. And like I said, under age 3, you may need to put something under those shoulders in the back to keep them in a nice flat position and keep that airway open. All right, so there's our picture of this little one with the folded towel underneath, and you can see his head still hitting the bed underneath him, but that leaves his airway in a nice straight line. All right, so our airways are narrower than adults. Who has seen the teeny tiny kid ET tubes, the 3Os, the 4Os? How little are they? Super tiny. Yeah, that's a good. We've got a straw up here. Yeah, so that's like a teeny little guy. Yeah, but like a little more than a pin diameter is what fits in a neonate. Okay, so neutral position is really important with them. Head positioning is super important. If you get them comfortable and they're in their little car seat and it goes like this and their sats go down, their airways kinked over. So trying to keep them neutral and their head back is important. You can also over hyperextend them. So you go, I remember, okay, this kid's not doing well, they're not breathing good. I remember I've got to do the head tilt, chin lift, and you get really aggressive. You can go the other way and they can bend. They're really flexible, so they can bend the other way and keep the tube that way. As I mentioned earlier, they are obligate nose breathers. They don't pop off and breathe through their mouth. This is why when they have a cold, feeding becomes terrible, because basically, think of yourself with the flu. Now chug a glass of milk. Who's up for that? Right? That's what they're like when they're trying to drink, when their nose is open. They can't pop off and breathe through their mouth. So clearing their nasal secretions are really important to helping them to be much more comfortable breathing. Their tongue is a lot larger than yours or mine. If you get a baby to open their mouth, you may only see tongue. And that's because it's filling up a lot of that cavity. When you have to intubate these kids, I'm saying again, when you have to intubate these kids, because at some point in your career, it will probably happen. Remember that tongue's going to be a big challenge for you. And it's really important to use good technique, sliding the learn, just get past it and sweeping it up out of view, because you can definitely catch it on the way in and push it into your view and make much more trouble. Their tracheas are much softer and more flexible, as I mentioned earlier, so they are very susceptible to narrowing their airway by change of head position. Their larynx is higher, and if you look there at the bottom, the epiglottises are there. Adult on the far side, peds on the near side. It's a lot bigger appearing. If you can just look, that thing just looks floppy. It's much more mega shaped than in an adult where it's wider. You can see, it looks just cartilaginous. It looks more solid. This thing's flopping around and getting in your way. So with that's just something to sort of anticipate and be ready for. It means pick the right equipment with them. If you use a Mac blade or a curved blade, it's going to go in where do you put that? Molecular. Where does a mill or a straight blade go? Yeah, so we're going to use that to just pull all of this loose soft tissue up and out of our way versus trying to sneak in right above it and letting its hard nature pull itself out of the way as you move the soft tissues. I'll say it again, keep the nares clear, keep the nares clear, keep the nares clear, because they're not breathing through their mouth. So if they're bubbling snot at you and in respiratory distress, suction them and see if that's going to help them out because they're breathing through snot. All right. We're going to open their airway gently. So when you are doing a intubation on a peds patient, it's your oh shit moment. All right, you're puckered, you're nervous, you haven't done one of these since your last PALS research and that was on a model, or I've only done 2 of these in my entire career. It's intense and it's nerve-wracking. When we get the adrenaline pumping, one of the things we tend to do is start to rush and start to fluster ourselves. Take a deep breath, just center yourself, get ready, and move slowly. Because it's not an airway that you're used to and your muscle memory is not the same. So move slowly and watch as you go. And make sure that you're not injuring the tissue on the way down, because if you are scraping a lot of things with the laryngoscope on the way down, they can get swelling in that airway from their sensitive soft tissues. Oral airways, nasal airways, those are things to consider if you've done everything else and shy of like intubation and you haven't gotten the airway where you need it to be. Those can be used to help to keep that airway open and let you bag a little better with them. All right, chest and lungs, so keep moving down the body. These kids tire out faster than adults do. So your CFer, they may let that guy sit at home with his fluid overload and huff and puff and wheeze and work for 2 or 3 days, and then they finally go, oh, grandpa's not getting better, we should take him in. The kid with bronchiolitis that's full of snot and tugging, retracting everywhere isn't going to make it that long. So if they're looking really tired in the rig, they probably are, and intervening to help them before they totally have the wheels fall off is important. Their lung tissues are much more fragile, so they are prone to barotrauma, which means I'm bagging this kid and I'm overly excited and I'm putting way too much force in there. You don't need to empty the entire ambu bag into their lungs. You need to empty enough for chest rise. Their ribs are much more pliable than ours. So the guy that falls off the roof, you're going to see flail chest and you're going to see those broken ribs. My kid may fall out of the tree and not have a ton of external trauma, but their ribs, which have a lot of cartilage still to them, have collapsed, and they may have a big pulmonary contusion or pneumothorax under there. All right. My belly in these kids, my abdomen. So as I talked about, disproportionately big head means disproportionately small trunk. But they've got to package all the same organs that you do. So things lie over top of each other. Their liver reaches all the way over and covers over their spleen a little bit, and the pancreas is behind there. So when they get belly trauma, you can hit all 3 of those ending a kidney with 1 blow to the belly. Versus an adult who typically, if it's, say, a punch to the belly, maybe a liver contusion in the kidney that lives in the right kidney, but the spleen and pancreas, which are further to the left, aren't as much of an issue. And they are at increased risk for visceral trauma. So these kids will get a lot of things like liver contusions, splenic contusions, kidney lacerations. Their extremities are a whole lot softer than adults. So for your first 13, 14 years of life, your body's concerned about making bones longer. Then you switch into making bones stronger. So you can get plastic deformities like that from a fall. Anybody see an actual fracture line in there? No, there's not one. Just that whole bone bent, it's bowing. Still gonna need orthopedics to help to straighten that out. But that's just a good example of how bendable they are. In peds, we talk about kids don't break, they fracture. So a lot of kids, when you think it might be an ankle sprain, may actually be an ankle fracture. So sprains, strains, treat them all like fractures and mobilize accordingly. If you're worried that it might be broken, the thing that's going to be most painful for that kid is two fragmented bones moving. So whatever you have to immobilize. If you have, if you don't have a splint that fits them, if you need to just even fold up some blankets, roll them, and tape them just to provide some extra support, do that and get them nice and padded. And then remember, my kids have open growth plates. This one's hard to see, but you can see that little bit of translucent line there. That's where they grow from. So there's a part of their x-ray that you can't really see. It's not radiopaque yet. When they get fractures in those areas, it may end up disrupting the growth of their arm. So like I say, doing everything we can early on to stabilize and not harm those growth centers any more than's already been done is important.
What's your thoughts about IO?
I love IOs. I already told you that I'm a pre-hospital, I'm a pre-hospital advocate. I actually like IOs. You need to review how big you have to be for different places. So most every kid that you're going to see can at least hold an IO in their distal femur. Yep, you're making a face.
Well, we didn't learn that.
You didn't learn that side. Okay, that's one of them that we use in peds. So proximal tibia is also one, and that's usually the easiest one to go for. So remember, you want to start further away and work your way up, one shot per bone. If you come to me and say, I got this IO, and I see 7 other puncture holes, we're gonna go, okay, we'll talk about that in a little bit. But you also have to remember that you have to be big enough to do certain places. So in adults, did you guys go over humeral head?
Yeah.
You need to be about 20 kilos to have a bone that's big enough to handle it. With IOs, it's kind of important to follow the rules with them. So the reason we set certain places for IOs to go is because we're saying that's an okay place for a blind needle to go in, and we're not expecting you to disrupt the major growth plate. So the tibia, most of the growth comes from the bottom. So I'm never going to say, hey, it's palpate above that ankle and just, jam right in there. That medial mal looks like a great place to land one. No, there's a huge growth plate there, and so you put an IO right into it. But you're pretty safe if you use good technique in the proximal tibia. In your adolescence, if you know how to do the iliac, okay, I'm getting no's. We didn't do that.
Does that you wait until adolescence for that one?
I have to confirm on. I would have to confirm on weight on it, but that's going to be a little bit older kid. That's more of an adult size to be able to hold that. And then I have never seen a sternal IO in a kid. And those things are wicked. If you have not seen a sternal IO, your assignment tonight is to get on YouTube and see the Army say, private, hold still, this is going to hurt for a minute, and watch that thing go in. If you're doing inter-facility transport and you guys are now absolute badasses and they put the sternal IO in and you sunk that IV because you're a rock star, and you're thinking, well, we don't really need that for transport. Remember, the sternal one needs a key to get it out, so don't try and jerk it out. Leave that be for somebody else, because there's a lot of needles in there, and your patient's really going to hate you
It's just not coming.
Yeah, it's just not coming. That's not the way to go. All right. So skin body surface area, like I talked about, these guys have, even though they're the little guys are chubby little Gerber babies, they're not great at holding their temperature. And then as they grow and start to elongate, a lot of them tend to become string beans. They don't have a ton of subcutaneous fat, so they can get cold pretty easily. Remember that their body surface area is much bigger than adults, so they have a lot more places to lose heat from than an adult. All right. Great movie, right? Yeah. Also, great example of caring what your peer group thinks. They're school-aged, and he got double dog dared, so you have to do it. But they were nice. They left Flick out there with his hat on and his scarf on, but he definitely, in addition to the Band-Aid that they tied on his tongue when they got him free, they probably should have checked out his fingers and toes and nose to make sure he didn't have a little frostbite, because it was pretty cold in Indiana there. Because of their body surface area, they are at higher risk for dehydration, so you can sweat off a lot more easily because you have more surface area. You get colder faster. So if you're at the ball game and you're totally toasty and your little kid keeps screaming, "Daddy, I'm so cold, Mommy, it's freezing here," they don't have a lot of fat. Wrap them up in another blanket. They're not just a wimp. They're truly losing heat faster than you are. And then chemical exposure. So if you're going on scene for a big chemical spill, that kid may have the same total volume of chemical on their skin as you or I, but they have a lot more body surface area, so they can absorb it faster than I can. Just going back for a second, the other thing to remember with them is in burns, they have different body surface area, so calculating their amount of burnt skin is different than adults. Your rule of nines doesn't necessarily apply with them because they have a disproportionately large head. Quick rule of thumb, because to be honest, I have to look up the kid version and remember which limbs are 18 and where 7 is, and because it's not the rule of nines, which is super easy, and all of us in emergency medicine love things that are super easy. A palm is about 1% for them. So if their little hand, you look at it and you're like, all right, it's an anterior burn on this side of their arm, and they have about 5 hands, it's probably about a 5% burn. So the respiratory system, they require a lot more oxygen than us. Anybody have a guess why? Metabolism. Why do they need all that metabolism? They're growing. So their body, its like whole goal at this point is, I just want to get to adult size. So I want to make more muscle. I want to make more bone. I want to make my liver bigger. I want to work on those neurons in my brain. I want to make them longer. So they're going to have higher metabolic demand. So oxygen is really important for them. They also have smaller reserves. They've got tinier lungs than a big person, so they don't have the ability to have a lot of extra floating around in there because they're using it and don't have as much baseline. So applying oxygen is pretty important in these kids if you're worried about their respiratory situation. They are especially susceptible to hypoxemia. What's the #1 cause of a code in a pediatric patient? Yes. So they are very susceptible. It's usually respiratory failure that led to circulatory failure. All right, their cardiovascular system is pretty vigorous, but again, they don't have a lot of reserves. Their heart is kind of pumping everything that comes to it. They can get pretty tachycardic. They can move that blood faster, but they don't have a lot of extra kick to put out more volume with each heartbeat in addition to going faster. Overall, they have a smaller blood volume than adults, and that's in absolute numbers. So they can't tolerate the same amount of blood loss as you or I. That's why you guys just did neonatology yesterday. When I did neonatology, you always had to prioritize. A consultant came through and said, we need these 37 blood tests to figure out what's going on with this sick infant. It might be this rare metabolic thing. And you call the lab and you say, how much blood is that 37 tests that I ordered? And they go, oh, it's just 8 vials. For you, you know, that's a trip to the probably a trip to the ER, because with your sprained ankle, you might have said it hurt your chest once and we'd have to rule you out for an MI, because that's what we do. But, you know, the nurse comes in, they pop their IV in and they pull a rainbow of tubes and you're fine. My little kids are not going to be able to give that much up. And so I know a lot of our medics here are really good about when they pop their IV and they pull their reserve tubes. If it's not free flowing, just go ahead and saline lock it or use that IV for whatever you put it in, because they don't have a ton of volume extra. Go for it.
So if we are getting blood,
Yeah.
kiddo, just go in the same order that you go do the capital.
So thinking about, like, green top is probably your most important, because that greens and purple tops are typically what most of the things we need in peds. So aim for those. The stuff like you may draw for coags, but there's very little in a kid that I'm going to need coags for. I think that's a gold top. Okay. Yeah, but let's say probably prioritizing to the green or the purple.
They're small enough.
Yeah, and then call it good. And like I say, and if you're fighting with it, if anybody that's stuck a baby, you know, sometimes it free flows and it's gold, and we're gonna go thank you, because it's hard to draw off the 22 gauge. But if you've put it straight in and you're like, this thing is not flowing at all, don't fight it. Yep. The most important phrase on the bottom is on the bottom of the stream. Can maintain blood pressure longer than adults, and they're still at risk of shock. What was you have one phrase you said in your story about your 9-year-old that made me go, ooh, that was a sick kid. Do you know what it was?
Tachycardic, hypovolemic.
Tachycardic I was okay with. Tachycardic was worrisome. Tachycardic is the red flag. Something's going on. But you said hypotension. They were hypotensive. They used all their reserve up when, we'll get into shock in here in a minute, but when kids are no longer able to compensate and hold their blood pressure, that's the scary place for all of us. So hypotensive is, we've moved into uncompensated shock. That is a sick kid. Come on. All right. As I just said, the kid may be in shock despite a normal blood pressure. Okay, so that's the other side of that statement. So yes, your tachycardia was important. Their decreased mental status, their tachycardic, their cap refill is slow. They look pale. All of those can be signs of shock. But then you run that blood pressure, and you get you've got a 10-year-old and it's 110 over 74, and you're like, a good place. This isn't shock. Yeah, it is. It's just compensated. They're holding that blood pressure until the very last. And so their shock assessment is more based on tissue perfusion and tachycardia. So that's where you're feeling out there. Are their feet cold? Can I feel pulses? What's their cap refill? Remember, cap refill is not that. You actually have to hold it long enough to get the pressure, or get the blood pressed out of the finger, and then count how long it takes to blanch back in. Shock, you're going to be hitting 3. You may have a kid that's got a normal blood pressure, and you're hitting 3, 4, 5 for their foot to reperfuse. That kid's in shock. They're just compensating. All right. And so we follow with shock. Inadequate tissue perfusion with oxygen is going to lead to hypoxia and metabolic acidosis, and bad things happen when you go into shock. So in our pediatric patients, things that cause it: loss of body heat in newborns and infants. So leaving them uncovered, leaving them out exposed to the world actually can lead them to shock. Hence why we keep saying, keep them warm, keep them bundled, consider their body temperature. Dehydration can do it. I no longer have enough fluid to push around. Infection can do it. That one we're all pretty used to because you do adults as well as pediatrics. Trauma, especially those abdominal injuries, because we're getting one organ or we're getting multiple organs usually. Multiple. So if you have belly trauma, shock can follow because you may have a liver lac and a splenic lac and a renal lac. And then the less common things that are going to cause shock: allergic reactions, poisoning, and cardiac events. It's a little bit different priority list than the adults that you guys are so used to, because cardiac is way up the list on adults, where things like MI and heart failure easily can lead to poor perfusion and shock. That's much less common in my age group. All right, knowing your vital signs is important, okay? So if you are going and you're picking up a baby for vomiting, and you do your beautiful assessment, you stripped them down and you counted their respirations, and the number of breaths per minute is 12. That's great, right? That's easy breathing. No, it's not enough. Because remember, they've got small lungs. They need to breathe faster to get their oxygen in, small volumes more frequently, and they also need more oxygen. All right, that same infant is screaming, crying at you, and their heart rate's 170. Are they an SVT? It's like 170. We're not okay to have that. Do I need to get the adenosine out? No, because 180 for a newborn is, I've seen my diaper changed. Again, they need a faster heart rate to deliver all that oxygen out to the tissues. The older you get, the closer you get to adult values. All right, it's hard to remember all of these numbers, but keep things tucked away. They're not just little adults, and if you have a newborn with vitals that are okay for you, it's probably not okay for them. All right, so normal blood pressure ranges. This one's a little tough too, because we're wanting to know, is that blood pressure okay or is it not? So average is what's in the chart. So our approximation of our systolic blood pressure is going to be 90 plus 2 times their age. Okay, so you go unseen to the MVA and grandpa's blood pressure is 93 systolic. You're probably worried about him. If the toddler is 93 systolic, his blood pressure is doing okay. All right, in red, because I can't say it enough, blood pressure changing is a late sign. Once it's happened, we've missed the boat. We're already behind the 8 ball. And the lower their blood pressure goes, the quicker we're approaching arrest. And then, does anybody know, have done PALS or knows the minimum acceptable blood pressure? Because I gave you average up in the chart. There's a formula for it. Anybody know that one? 70 plus 2 times the age is the lowest acceptable. So 74 for a 2-year-old is the low end of blood pressure. 74 in a teenager is not acceptable. That's more like an adult range where you would expect them to be. So they are hypertensive. All right. So I've already mentioned it, compensated shock. Compensated shock is where we've got increased heart rate, increased respiratory rate. Where's our blood pressure? Normal or abnormal? Fairly normal or normal. This is reversible. This is where we intervene and things get better. Decompensated shock, the hallmark for that is that drop in blood pressure. This is where we're starting to get end organ damage. This is where we're going to start to see our problems of poor perfusion, okay? So I have the advantage, I'm sending blood to the lab work and looking back at it so I can see a rise in creatinine to know the kidneys are in trouble. The easiest one for you guys is mental status. The hypotensive patient with decreased mental status, that's a bad sign. They are in decompensating shock and we need to act. it's typically going to be either a significant fluid loss or we're not pumping well, so it decreased cardiac output. When we hit into irreversible shock, that's the point where it's too little, too late. We've gone beyond what we can revive, and there's already overwhelming end-organ damage. All right, so hypoperfusion in a kid. What sort of things are you seeing? You can read them off the board, throw them out there, or you can just be really smart and know them yourself. All right, I'll keep.
For, I guess, increase in cap refill time.
Yeah. So we go delayed is an easier way to do it because increase sounds good, but it's bad. So delayed longer than we expect. So you're pinching that foot and it's already, so there's going to be more to that foot when you grab it because it's gonna be pale skin, it's gonna be clammy skin. Potentially it can even look a little cyanotic down there, and then you squeeze and you blanch it out to white, and then you're hitting 5 or 6 on your timer, and yeah, it's definitely one. A baby in shock, vigorous cry.
Dry tears.
No tears, and potentially just kind of whimpering or nothing.
Dry mouth.
Dry mouth, it's a good one. Dry mouth can be before you get into shock. That can just be sort of in your dehydration on the way, but it's a key.
Increased urination, probably less sweat.
Yeah, so mom saying the baby hasn't made a wet diaper, so and when they have to start thinking and counting how many yesterdays it was, I think, yeah, I changed a diaper on Monday night. It's a bad sign. Baby should pee at minimum 3 times a day, but most of them pee every time you give them some fluid, so going more than 24 hours is a very, very bad sign. Was there something up here that could help us? Fontanelle, yeah. If it's the Grand Canyon when you rub your head across the top of that kid's head, that's also another sign that we are pretty behind on fluids. We're in a bad place. All right. Just coming to listen, or perfect. All right, back to our anatomy physiology because we figured throwing some shock stuff in there with the cardiac system was important. So our nervous system, we're developing that throughout our childhood. We're going from that little baby that I said doesn't recognize the world is out there and just wants to be in their tiny little cocoon of warmth, all the way up to the teenagers that are ready to go off to college with them. So while they're developing, their neural tissues are fragile. Concussed kids can look very ill. Concussed kids can look very similar to a kid with an epidural. They may be altered, they may be confused, they may, have a decreased GCS, all from just concussion. That is the loaded pediatric word, lethargy. Parents love it, and so true lethargy in my world is the down and out of it. And yes, you can absolutely see them. Lethargic children need an ET tube or a spinal tap is sort of where I think of them in terms of using that particular word. They are not responding. They are not interacting with the world. So it's a loaded word, but yes, you can absolutely see the kid that's beyond malaise, that is just kind of there on the stretcher. With them, because their neural tissues are very fragile, they're a group that you want to be really careful with in trauma in terms of protecting their neck and their spine. They can have much less force to cause bigger injuries. Remember, we've got a pivot here, an extra weight up top, so that fulcrum is really susceptible to injury. And they are very susceptible also to soft tissue injury. So if you're worried about the neck, immobilize it. Nobody's going to fault you for being overly cautious in the high-risk population. All right, there are metabolic differences between my kids and the big people. We kind of talked to this a little bit about this. Do they need more or less oxygen than adults? More. They need more or less glucose. More. And they need it more regularly than we do. Glycogen gets stored when we eat. You're having your lovely snack there. Your body goes, all right, I need to raise my blood sugar like 3 points, and the rest of this I'm storing away for my liver because I'm going on a run tonight. And so I'll need that at mile 3. That's what our bodies do. Kids don't have the same storage space, so they don't have the backup reserve. So they're much more susceptible to getting hypoglycemic than adults, particularly those under the age of 1. Again, we talked about they're prone to hypothermia because of that, the body surface area differences. They're also much more susceptible to volume losses. The 3 episodes of large volume diarrhea that the toddler had is going to be much less tolerated than the 3 episodes of large volume diarrhea that their teenage sibling had. All right, so we're moving on to the pediatric assessment triangle. So appearance, work of breathing, and circulation. How do we look? How are we breathing? How are we perfusing? All right, so like all things we do, primary assessments and secondary assessments. Primary assessment, the flyby, big bads, what's going to kill you now, and do I need to intervene? Secondary assessments, let me look for other reasons for why we got where we are. So the primary assessment with them, that's your rapid, eyes-on, hands-on approach to the kid. Appearance, what's their mental status like? What are they able to sit up and talk to you, or are they weak and just lying on the bed or on the floor? What's their muscle tone look like? Breathing, that's respiratory rate, that's work of breathing. If mom calls you and she was really nice for you and went ahead and bundled the baby into the car carrier, and she's got the onesie and the fleecy and the blanket over top, and then she's got that sheet, the zipper thing that encloses the hole because she knows you're going out, and you see this much of the baby, how's their work of breathing? You can't tell. So that's why it's hands-on, eyes-on. You gotta look. My kids can look pretty okay in their face, and then you unzip and finally get to the bottom layer and get to skin, and they've got retractions and they're everywhere in their belly. So taking a good look at their respiratory efforts is pretty important. They do, like their blood pressure, they do a lot to maintain their oxygen status too. All right, so primary assessment, we're looking at circulation again. That's looking at our skin signs, our cap refill, our pulses, as a way to determine good perfusion or bad perfusion. And then evaluate the vital functions. That's your mental status. Are they able to talk to you? Are they alert? Are they, a GCS of 4? And then with all this, the ABCs. So ABPU is a pretty easy way to rank their level of responsiveness. Are they alert? Looking around, playing around. This is getting long. Some of you might have been moved into the R group, that you're responding to verbal stimuli, but you're starting to fall away from me. I don't want you to go any further to the P, where we have to have response to painful stimuli, and I have to pick something up here to chuck at you. Or, oh, there's a good one. I can just call on the kid behind it, a whack on the back of the head, like you. Or you're totally unresponsive. All right, and you just remember to adjust your technique of how you're assessing mental status based on the child's age. The kid that is a 2-year-old that's lying there with their eyes closed, gentle stimuli might be okay first before you go in and sternal rub them. They may just be napping. Think about it. That's a way to make a best friend. I talked about, like, they don't trust people. So if you just walk in with your knuckles and just rake them right down in their chest, that's the best way to make a best friend. And remember, airway and respiratory problems are our most common cause of cardiac arrest. So moving on to the airway portion of things. Is the airway patent? Is it patent for now? Or is it not at all patent. Is sort of what you're looking. Thinking about this patient, are we in a good place? This kid, I got called because it seems more like a worried mom situation, and now I have a toddler that I am running around and chasing them, that they still want to be transported for evaluation. That kid's airway is probably going to be fine for the whole route. The kid that is working hard to breathe already, you got to think about the duration of your transport. So do I need to do something now before we get in the back of the rig and have to do something sitting on I-90 in traffic? Or is it just not maintainable at all? I pulled this kid out of a house fire. They have no eyebrows anymore. There's soot everywhere inside of their mouth and their nose. They're fine now, but that airway swelling is going to hit. And I was, covering extra in a really remote location, and my hospital's 30 minutes away. That's a foreseeable, badness that you need to go ahead and take care of beforehand. All right, so opening the airway, you can slip inside their little mouth and use your thumb and hook it under their gum ridge and just pull forward. In neonates, they don't have teeth yet, so they're not going to bite you. It's one way. Head tilt chin lift is a much more common one that we know a lot better. Are we jerking it all the way to the furthest point it can go? No. Remember, we're opening to the point that we're getting a nice straight line for our airway, but not going so far that we're tipping in the other direction. Jaw thrust. So this is your good one for your trauma patient. You're worried about C-spine. You don't want to go manipulating their spine because you don't know if they have an injury or not. You're grabbing the angle of the mandible on both sides and giving a good tug forward and pulling the jaw, which will pull that tongue up with it to get it out of the airway. All right, so then we're going to look at their chest for movement. We want to see that their breathing is adequate. If you're breathing 30 times a minute, but there's really just minimal chest rise, that may not be enough, even though the number's okay. So you want to look at the number and the patient. We're going to listen for breath sounds. There's a lot of things that can go on in kids' airways. I talked about with them their pliable chests. So do you have eps and breath sounds on one side that indicates there might be a pneumothorax under there, even though their ribs don't seem broken? It's possible. Your breath sounds may also give you an indication of where you're going on the medical kid in terms of therapy. If they're wheezing all over the place, albuterol might be useful. If their lungs are clear, but they're making this sound, that's stridor. Albuterol is not going to fix that one. Stridor needs racemic epi because it's an upper airway problem. So listening to your breath sounds, knowing what they indicate are important. Feel for that air movement in front of their mouths. You can put a hand there. It's pretty easy to feel if anything's coming out. And remember that not all tachypnea is the result of ventilation problems. Pain can drive up your respiratory rate, and fear does too. And especially those toddlers that know they don't know us can get pretty nervous with the new people around. If you suspect trauma, do a good head to toe look for signs of life-threatening injuries. With the respiratory rate, tachypnea is going to be your first manifestation of your respiratory distress in infants. What that means is they're going to breathe fast first, then they're going to start working harder to breathe at a fast rate. Then they're going to run out of muscle, because we talked about that. They're going to tire out, and they'll fall into bradypnea. Then they won't have oxygen. Then their heart will slow. Then they'll code. So it's a continuum with them. So watching for that tachypnea may be your first warning sign that something bad is coming. And as I said on the bottom, slow respiratory rate in the acutely ill child is an ominous sign because we need that oxygen for these kids to survive. All right, respiratory effort. I've already kind of touched on this one as well. How well are they breathing? Are they having SATs of 100%, but to do that, they are nasal flaring and tugging here, and tugging here, and tugging here, and belly breathing, and doing it 100 times a minute? They're in distress, even though the oxygenation, or their pulse ox looks okay. Cyanosis is a fairly late sign in them. They do everything they can to maintain a good oxygen sat, and so they can be really distressed and not blue yet. All right, so I just went over some of these. Our signs of respiratory distress. Our altered mental status, why's that one on the list? Anybody have a guess? If your oxygen's down, you're not perfusing your brain says, I'm not having that, and you get loopy. Flaring your nostrils, pale lips, stridor. A baby that is rhythmically crying with their exhalation is not crying. Is not an unhappy child. It's a child that's grunting to push their air out. That one's one that's a little subtle sometimes, and it's harder to pick up on if you're not thinking about it. And then, like I say, the rapid breathing and the increased work. All right, so in our primary assessment, we're moving on to heart rate, tachycardia. So there are a multitude of reasons. I realize probably the number one reason that I see tachycardia is not even on this list. Fever can make your heart rate go up. Crying, anxiety can, pain, infection. So just because their heart rate's going fast, I have been beating think sepsis, but there's a whole host of other things there that can cause that. So look at the whole patient to think about why their heart rate's fast. And then bradycardia is a bad thing. In your teenage athlete, bradycardia may be okay. You're a super fit kid. It's going to be the same as the 22-year-old marathon runner that you picked up for a broken ankle, that his heart rate may be 45. The infant that you pick up should not be 45. Peripheral circulation, again, that's our good indicator of our peripheral perfusion. If you've got really poor cap refill in your feet and in your hands, you've got to think about where else is it getting perfused. If you can't palpate a femoral or a brachial pulse, that's a bad sign. If you can't palpate it, take a breath. Don't freak yet. Reposition your fingers. Ask somebody for help. Can you find one? But keep in your mind that it may be absent because you need a systolic blood pressure of about 60 to feel those sort of pulses. And if where 60 wasn't on those acceptable lists of blood pressure for anybody. Yes, sir.
On these kiddos, what map does their kidneys normally get used at?
It's variable by age. With kids, because their blood pressures are arranged, the map that you're aiming for is arranged as well. So I don't think I have a list in here of where to keep map, but most of the PALS cards will have that sort of stuff on it. That's a good thing to have in your pocket to look at for your reference range, rather than trying to memorize an ever-changing list of numbers based on age. All right. So in these kids, remember your GCS, that's something that you always get asked on the far end. That's going to be different in kids because in adults, if you say, where are we? And they go, oh, that means their speech is being dinged because they have mumbling, incomprehensible speech. And if you ask a toddler where we are and they go, still incomprehensible, but probably age appropriate. All right. Think about your vital sign instability and let the receiving hospital know that those sort of things. I'm bringing this one to you and they're tachycardic. I'm bringing this one to you and they're hypotensive. I'm bringing this one to you and they're tachypnic. It's going to help predict how their outcome is going to be and help you decide who needs to go first and who needs to go fast. All right, so I mentioned GCS is different because my babies are different. So under a year, I can't say open your eyes and expect a 6-month-old to do that. But if I shout at them, they should probably look and figure out where I'm You guys have the notes, so I'm not going to go through everything on there. All right, so secondary assessment. This is where you're going to have your chance to get more of a focused history, more of a focused exam. You can do that en route to the hospital where you're gathering more details. Like I talked about, we're involving both the patient and the family member and caregiver. They may be able to give you more clues. Again, we talked about with the older patients, we want to get some questions in private with them so that they are able to disclose some stuff they might not want to say in front of their family. And this is where we're going to grab more information about their past medical history. This is where you're going to find out exactly what happened, how long, have they been showing other signs that they're sick? Do they have a fever? So just general history questions there for you. And this is where you get your exams. Big people, big kids, probably school age in the adolescent group, you can use your routine exam just like you would with an adult. Start at the top and work your way down. The little ones, it's easier to remember to go toes up because you're gaining some trust with them and going to do least invasive things first. With them, remember, pupils can give you a lot. So the toddler that's you're calling or got called for decreased mental status who has pinpoint pupils, they might have picked up somebody's OxyContin off the floor and eaten that and have a narcotic overdose. You may look at them and say, wow, that right one is 3 times the size of the left one after they fell. It's a bad sign. So looking at those can give you some clues as to what's going on. I can't say capillary refill and hydration status enough because, again, we're looking at volume a lot of times in these kids. And then pulse ox, remembering that kids are going to work really hard to maintain good oxygen sats as long as they can. All right, vital signs you want to do as close to the resting state as possible. That seems like kind of an obvious statement because most people think, yeah, I go and pick up that 60-year-old and I put him on the stretcher and I set everything up and go. The little ones, you may be making some compromises as you're doing that. So you may have the pulse ox while they're moving around because they're scared of it. But trying to get things like blood pressure and heart rate, it's better if you can get them to be calm and quiet for those. And remember that crying affects things like heart rate. So if you can get them calmed, you're going to get a more accurate reflection of where they are currently. And then we're moving on. So secondary assessment, we're looking at our peripheral pulses, our brachial pulses, our femoral pulses. Make sure you're getting a good estimate of the kid's weight. If you need to do fluids, if you need to do any meds, you're going to want to weight base those. What a 2-year-old can tolerate and what a 12-year-old can tolerate are much different. So Broslow tapes are really useful. If you don't have one of those, ask the parents. Do you remember what he weighed at his last appointment? And just kind of having general ideas of what's normal can help you out a lot. Because being metric, a lot of us don't think like that early on. We're very used to our pounds situation. And so you may go, oh, 25 kilos, that sounds right for a 1-year-old, but that's like 50 pounds more than. Measure your temperature early on in your interaction with them. Again, because they're susceptible to hypothermia. If you want to know what they are, it's doing it sooner to them being picked up is going to get an more accurate reflection of where they were when the event happened that led to you guys being called. So in non-invasive monitoring, those that are seriously ill or injured, you're going to want to do continuous pulse ox on them. With them, your goal for transport is probably 94% or better. I tolerate a little bit lower in the emergency room, but I also have more things to intervene and I have more help to be watching those sort of things. So kind of for those of you that are going to be running and doing multiple things in the back of the truck with maybe another set of hands or your other set of hands is driving, 94 is a good place to intervene if they start to go under. If you have capnography, that's great because oxygenation is one thing, but how are we ventilating as well? Knowing that we're actually getting rid of the CO2 is pretty useful. So if you have that ability, using it in the critically ill patient is useful.
So that's, should their cap level
Be the same as ours, 35 to 40%.
Yeah, that one. So oxygen sats and capnography follow adult trends. Yeah, they should be exhaling about the same. So if you put capnography on and it's 70, they haven't been ventilating well, and if it's 20, they've been doing too much. They're probably hyperventilating. Again, with them, if the kid's conscious and alert, explain what you're doing before you put it on. If you just walk up to a 3-year-old and lift up their shirt and start smacking stickers on them, they're going to freak out. Call them stickers. Use words that are kind of friendly to a kid. So I'm going to put some stickers on your chest. I'm going to make your finger glow to put a pulse ox on. Show that if you've got the clamshell one, show them there's nothing sharp in there. Put it on your own finger because they're like, is that thing going to pinch me? So if you've got time, explaining to them goes a long way. All right. She looks real happy to have her pulse ox on, by the way. But it's a really useful non-invasive tool for you guys. All right. And then reassess them. They can decompensate quickly. They can change quickly. So you want to keep looking at them again, not just assuming that they're going to be what they were when you pick them up 5, 10, 15 minutes later. The critical kid, you want to get a new set of vital signs about every 5 minutes. The non-critical patients, the stable ones, reassessing it like a 15-minute mark is useful if you've got a long transport. All right. And then the other part of that, in the middle one, retake your vitals and compare it to where you were. Because there is a range. So you go and you're picking up a toddler that got into grandpa's pill tablet. And your first set, or your first blood pressure you got while the kid was calm and cooperative for this 3-year-old was 98 systolic. Good, right? Because we said 90 plus 2 times their age, and they're 3, so 96 is about average. 98? Great. Okay, we're in a good spot. And the kid's stable, and I'm going to watch them. And then you check them again at the 15-minute mark. And now they're the same calm and cooperative patient, but their systolic blood pressure is 79. Make the case. But our minimal accepted, we said 70 plus 2 times the age, so 76, we're still perfusing, right? But we've dropped almost 20 systolic points. So even though you may still be in the range of normal, looking at that trend can say, well, if I wait and we're staying on this same pattern trajectory that we're at, I wait another 15 minutes and we drop another 20 points. Now we're going to be 56, and that isn't acceptable. So looking at what your numbers are compared to previous can help you out to identify changes early. All right, so as with all things EMS and emergency medicine, your top priorities are A, B, C, airway, breathing, circulation.